Our next speaker is Dr. Sanchay Dhangar, and his topic of interest is Peyronie disease, medical and surgical management.
Pathology practice, we try to manage all the things medically. So 90% of the management is medical management. So Peyronie disease is basically named after a French surgeon, Francois de la Peyronie. He published a paper in 1743 over the disease having a plaque in the penis. So the disease got the name after him. Basically, Peyronie disease is a wound healing disorder. So there is an abnormal healing response. Normally, when there is any wound, the healing response is associated with the remodeling. So remodeling is good because it gives a nearly normal look after the injury is gone. But in Peyronie's disease, what happens is there is abnormal remodeling. So because of this abnormal remodeling, it leads to formation of a big scar in the form of a plaque, which leads to various form of deformities in the form of curvature, indentation, hinge effect, sometimes hourglass deformity, and there is distal softening of the glands, and many times it is associated with erectile dysfunction. Patient may come to you with pain either in the flaccid state or in the erect state. Then there will be pain during intercourse, especially there is a top pain, because top pain happens whenever there is the penis is erect and there is a tension at the site of plaque. Now I tell you few misconceptions. It is a rare disorder? No. The thing is, as a urologist, I am seeing at least 3 to 4 patients every month. So this is not so rare. Another thing is high likelihood of retention. High likelihood of resolution. In fact, the disease doesn't resolve by its own. You have to do something for the resolution. Then comes disease is only of the middle age. No, the disease starts early at the age of 30. It progresses linearly till the age of 50. And at the age of 50, there is an exponential increase in the number of Peyronie disease patients. So, it is not a disease of only middle-aged people. Then, only Caucasians? No. Again, it is found in all varieties everywhere, all over the world. So, it is disease of just human. Then, plaque calcification is an indicator of mature chronic phase. No, it is not. Previously, it was thought that if you feel a very hard plaque in the penis at one place, we thought that it was a mature disease, but no. This depends on the genetic composition of the type of calcification that is involved. So, genetic pathway that is involved in the calcification determines whether it will be a hard or a soft plaque. Then trauma to the erect penis. No, trauma can occur either in the flaccid state or in the erect penis state. The theory says during erection, the normal pressure in the corpora cavernosa is around 100 millimeter of mercury. So this pressure, if during intercourse this is associated with external pressure over the penis. So external pressure associated with the intracavernosal pressure of 100 mmHg may, if this pressure exceeds the elasticity and rigidity of the tunica albuginea, then it may cause small or micro breaks in the tunica albuginea. This may lead to micro fractures, and if the process is repeated, then this will lead to formation of the plaque. So clinically, we can diagnose by taking history and examination. So history is patient will come with you with pain, formation of some hard substance over the penis, bending of the penis, there will be talk, and many more. But clinically, we can just see the angle with the help of this goniometer. So this will help you clinically judge whether it is a mild disease, moderate disease, or a severe disease. The classification was given by Kelavi et al. So as per the degree, if the degree is 30 or less, then it is a mild degree of Peyronie disease that is causing curvature. If it is 30 to 60, then it is moderate, and if it is more than 60, then it is severe degree of torque because of the Peyronie disease. Then coming to the treatment. Treatment actually is basically conservative along with few medications. Surgery stands at the last when you are not able to deal with the medical management. And of course, if it is associated with erectile dysfunction, then we can think of doing prosthesis surgery along with the Peyronie disease surgery. So surgery is indicated for those people who are not willing for surgery, not fit for surgery, then who have minimal symptoms, and the degree of curvature is less than 30 degree. So this is a long list. Those marked in red, they are available and we are using it routinely in our clinical practice. So the first one is Potava. It is potassium aminobenzoate. This comes in a tablet form, 500 milligram tablet. You can give it 500 milligram QID or 800 milligram TID. So this helps in decreasing the antifibrotic activity and decreasing the size of penis. The torque may or may not decrease, but the size of plaque may decrease. Apart from this is the pentoxifylline. Most of the surgeons are using in their patients. So this acts like a PD5 inhibitor, but this is non-specific PD5 inhibitor. So it helps in decreasing the curvature. Again, this is available in tablet form. It is 400 milligram tablets, VD or TID. Then Virapamil is available in injection form and in cream form. Cream is not easily available. Injections are easily available near cardiac center anywhere. So Virapamil increases the collagenase activity, decreases the curvature. The dose is 10 milligram diluted in 10 ml and it is given intralesional. So most of the agents are oral or intralesional. Then again, last one is the Clostridial collagenase hematolyticum. So this is CCH. So this basically works on the basic collagen tissue of the corpora cavernosa. It decreases the collagen. So if the collagen tissue decreases, the curvature will automatically decrease, and the bothersome by the patient related to the torque and the plaque formation will decrease. Then comes few local therapies. This is one is ESWT. ESWT, there are 3 randomized trials done all over the world regarding the ESWT. So ESWT basically works by increasing the vascularity, and if the plaque is, like previously we thought it is mature, so if it is calcified, then this ESWT will work very well. Apart from that, 3 trials have been done all over the world. I have been a part of one trial, but it suggests that it is more of a placebo improvement than a real pathologic improvement. So those who are having this machine can use it because this gives a psychological advantage to the patient, not because patient is psychologically disturbed. So even if you offer any treatment, he will be benefited psychologically. Doctor has seen me and he has opted me a conservative management or a minimal invasive management. So that thing gives the patient advantage. Then comes penile traction. Penile traction again, it is basically a physical form of traction that we use in gym to build our muscles. So similarly, it is increasing the traction. The traction is applied at the base of penis. Thank you. So for traction, first you have to measure the length of the penis. So you measure the length of the penis from the pubic base of the pubis, where you can feel this is a fixed point. Another fixed point is the corona below the glans. So these 2 points are fixed. So if you give, whenever you give traction is given for half hour to 2 hours, but it should not be more than 6 hours. It should not be like that I will just gain every length in one day. So it is a slow process over 3 to 4 weeks. Measurement of the length is very important in this case. So fix the points, measure the length. This will help in decreasing the curvature, increasing the length of the penis, sometimes decreasing the sometime beginning the plaque present in the Peyronie disease. And another thing is, patient is very happy that I have been given some treatment and this is really helping me out. Second one, this is vacuum therapy. Vacuum therapy works like a physical traction and it helps in decreasing the angle of curvature. Radiation therapy is not of much importance. And finally, there is one more thing. All these conservative management, they work better in a combination. So pentoxifylline along with L-arginine. L-arginine works like a PDE5 inhibitor. So it enhances the erection along with bi-weekly injections of verapamil. Injections are given every 2 weeks for 6 weeks. And traction, daily traction. Traction should be given at least 1 hour after the injection verapamil. So all the therapies, if they combine, they give at least 70 to 80% good results with a good patient satisfaction. Surgery is indicated whenever patient is in a hurry to get a good improvement. If the degree of curvature is more than 60 and patient is distressed because of the appearance, then there is a trial failed of the medical management. You have given all conservative treatment, it is failed. And lastly, patient pain, there is a pain to patient or the partner because of the plaque. So deformity basically, if it is a dorsal plaque, then there is not much problem during the intercourse because it is easy to enter the vagina with the plaque at the dorsal position. But difficulty comes when it is ventral or lateral. Ventral is also fine, but in lateral, if it is combined with the irregular formation of the plaque, it may lead to a irregular plaque formation, R-plus deformity or I-beam effect. So if these form of plaques are very distressful to the patients, in fact distressful to the surgeons also, the reason being because it is very difficult to excise completely. So surgery is indicated in all these cases, and then most important part is the counseling and explanation to the patient how much improvement will he get. So counseling is one. First question should be, are you satisfied with the type of erection that you are having now, and are you able to do intercourse with such erections? If patient is happy with that degree of rigidity of erections, then you can proceed with the surgery. Another thing is, what you call is 100% correction is not 100% correction of the deformity. It is less than 20% of the deformity that is able to correct. Otherwise, 100% we are not able to correct. The only thing is, there is no tissue available in this world that can beat tunica albuginea. We have everything in the body. We have bone tissues, we have porcine tissues, pericardium, small intestine, everything. But no tissue can beat tunica albuginea. The elasticity, the strength, the stretching effect, everything is only with the tunica albuginea. So less than 20 degree is considered as nearly complete correction of the deformity.
20 degree correction or 20 degree remaining?
Less than 20 degree, if it is left, then it is considered as you have done a good correction.
Okay, 80%.
Yes, so 80% is fine. So the procedures are, one is tunica shortening procedures, tunica lengthening procedures, and then finally the prosthesis. So tunica shortening procedures are two, Nesbit's and Yachia. In the Nesbit's, you remove a small part of the tunica albuginea and suture it back. This is normally a horizontal cut is made. The small part of the tunica is removed and rest of the tunica is sutured. In the Yachia procedure, it is same, but you give a vertical incision, but you don't excise the tunica albuginea. You suture it in the horizontal fashion. So this gives a straightening to the penis, but these procedures could lead to a shortening of the overall penile length. So this should be informed to the patients prior to the surgery. In the lengthening procedures, you can do multiple incisions over the plaque. Multiple incision means if the plaque is too big, you cannot remove it. Then giving multiple incision will give a mesh effect. So mesh effect will enlarge the area of the tunica albuginea. Then plaque excision. If you are able to excise the plaque, then excise the plaque and If it is a small, then you can directly suture it, and associated with that you can do a Nesbit's or Yachia procedure to correct the deformity. So the length will be adjusted as per the excision of the plaque.
Unica is regenerative. Unica can be regenerated. Is it?
No, till now not actually. That's why I was listening to Dr. Nadesh Prabhu's lecture. We can regenerate corpora cavernosal tissue, and that helps in decreasing the collagen content and increasing the smooth muscle content. But we cannot regenerate tunica albuminia. It is again a fibrous tissue, so it is very difficult to grow. Then grafting, you can use the autologous or the non-autologous graft. So autologous graft, we have rectus sheath and fasciolata. Many a times, patient is not willing to pay for the non-autologous graft. So at that time, we take rectus sheath. It is around 6 by 4 centimeters, so it doesn't matter for the rectus muscles. Then we can suture the rest of the rectus sheath. But the qualities of tunica albuminia cannot be matched. So, but because it is autologous, so there will not be any foreign body reaction. In non-autologous, we have human and bovine pericardium, porcine, small intestine, mucosa. In the market, human and bovine pericardium are easily available. Human is less, bovine is more easily available. So the 6 by 4 size graft of bovine pericardium comes at the cost of around 33,000. So normally those who are sexually active, patients who are willing to correct the deformity, they are ready to pay for this, and it is very easy to do that surgery. The only thing is during surgery you have to preserve the neurovascular bundle that is present at the dorsum of the penis. So if you are not able to preserve that neurovascular bundle, then the remaining erection will also go away. So take care while doing surgery that you preserve the neurovascular bundle. Post-operatively, in these cases, what you have to do is you can start immediately patient with PDE5 inhibitors just at night, just to increase the vascular supply to the penis during night, and erection will give a traction effect, just like we are giving with the vacuum or penile traction therapy. Similarly, if pain is decreased in 1 or 2 days, then we can start the penile traction therapy post-operatively in these patients. So combined management is always important in these cases. Finally, if everything is being done, not working, then penile prosthesis is the option for patients who have failed surgical treatment that I have discussed just now, and patients who are having concurrent erectile dysfunction. The only thing is, after listening to Dr. Nadesh Prabhu's lecture in my last conference and this, I have started going again penile prosthesis. The only thing is, when we are doing penile prosthesis, we are crushing the corpora cavernosal tissue. We are not helping the patient giving erection. It is the prosthesis that is giving erection. Though we say that you should have some erection, but it is the erection that is given by only the prosthesis. If you are destroying the cavernosal tissue, you cannot regrow it without doing anything. So before thinking of penile prosthesis, always think of preserving the native corpora cavernosal tissue, so that you can give more and more time for the medical and conservative management before proceeding to that. In India, Shah prosthesis are easily available that we are using. The cost is around 80,000 for the prosthesis. Rest is the surgical cost. So we are doing in India, we are doing this prosthesis regularly, and inflatable penile prosthesis, they have to be bought from outside. The cost is around 8 to 10 lakhs for 3-piece inflatable penile prosthesis. Though this is very good, you can have erection as per your wish. There is a button in that, in the scrotum or in the groin region. You can just press the button, the saline will fill the cylinders, and you will get erection. But any malfunction of the pump or any infection after inserting the prosthesis may lead to destruction of the rest of the corporal cavernosal tissue. So better is try to go for the conservative management as far as possible. Thank you very much.
There is a role of PRP in pyroludities. I have seen video of the cases.
Yeah, there is a role, but PRP doesn't work well as compared to, there is a different thing that just Dr. Nadesh Prabhu told downward in the lecture, that better than PRP is something better than the
PRP is the PDE5.
Yes, it is from the patient's autologous. So it is the autologous PRP. But there is another thing from PRP, I don't remember that he discussed, but it is working better than the PRP. PRP is in trial actually. There are no trials done till now. In fact, next year for my students, I am going to give 2 theses regarding the PRP. One is for the females for SUI and one is for the pulmonary disease and erectile dysfunction. So we'll see whether we are able to really get any benefit with the PRP or not.
So we can use the steroid injection for the place, fibrotic place, like triaxone.
We can use, but it doesn't work well. Though previously in olden days we were using that. Even my bosses were using intralesional steroids, but steroid doesn't work well. If you give CCS, collagenase hydrochloride, and apart from that, if you give virabamil injection, they work better.
You say oral pentoxephalline or injectable?
Oral. It is available in 400 milligram tablet, so it is 400 milligram BD or TID.
What about tranexamic acid? Any evidences?
No. You can give anything because patient have a psychological benefit. So you can give anything, but as said, so few things I marked in the red. Only those have a clinical benefit and work has been done over those agents. Rest of the are all in the this research purpose. They are not helping.
Thank you, sir. Any other questions?
It is a physical traction, so you can just tie 2 ribbons, one at the base and one at the corona, and you can give traction with graded weights. Weights come with a hook in them, so you can just tie the weights with the hook or a thread. It will give a physical traction.
No, there is canal extender.
Yes, machines come. Yes, machines come for that. Yes.
They are the same one?
Yes, same one.
This is day exercise or night exercise?
Anytime. Anytime, whenever the patient and the doctor is ready.
Comfortable.
So we are making great incisions, multiple incisions from
Yes.
here. Once again, the fibrosis is going to, we are putting an interposition of buccal mucosa grafting between the.
No, the thing is, for small incisions, you don't need to take any graft, and buccal mucosa will not work because it's very, very soft as compared to rest of the rectus sheath or the Bohan collagen, this pericardium. Because you need something like a tunica albuginea. So buccal mucosa doesn't work at all. In fact, it will give a opposite hinge effect and a torn effect. So we are not using buccal mucosa because of this reason. Small incision, they heal by own. The only thing is whether they will heal with the same plaque material or they will heal with the normal tissue, nobody knows. It's like we are doing some experiment, only God knows what will go to happen.